Welcome to everybody who's joining. We're just waiting for more attendees to access the event. So thank you for your patience as we just wait for a few more people to log on. So it looks like people are trickling in, and I'll take the opportunity to get us started and to introduce myself and the Canadian Psoriasis Network before I turn it over to our distinguished presenters tonight. So my name is Antonella Scali. I'm the Executive Director of the Canadian Psoriasis Network. And for those of you who don't know us, I just wanted to share a little bit about our organization. We're a nonprofit organization dedicated to enhancing the health and quality of life of people who live with psoriatic disease in Canada. And we do that through building awareness and education and putting on events like these ones. So we're very happy that you could join us tonight, and we're very excited to take a deep dive into the topic for tonight's session about psoriatic arthritis. Just a little bit of housekeeping. You may have seen that the webinar is being recorded, and it will be available on our website for a short time in English and in French. So if you missed any of it, you can check it out again. All the participants will be in listen-only mode for the duration of the session, just to make sure we can record well. So if you have any questions, please do put them in the Q&A box or in the chat box, and we'll be excited to get to them at the end of the presentations tonight. Our first speaker, Dr. Ahluwalia, will welcome questions as she won't be available for the Q&A at the end of this session. But if you have questions, you can always share them back to us and we'll pass those along. All of our webinars and resources are general information only. So any questions that we do get, we'll be answering from a very general perspective and not from an individual health question. So just to remind people about that. And that the information shared here is based on the personal or clinical experience of our experts tonight. So we'll be very excited to hear from them. And I also want to, of course, acknowledge that this webinar was made possible through an educational grant by AbbVie. And we just want to thank our sponsors as well for making these events possible, and specifically for tonight's, having us be able to put on tonight's webinar. So a little bit about tonight's webinar before we turn it over to our speakers. This marks the end of Arthritis Awareness Month. So September is Arthritis Awareness Month for those of you who don't know. So we thought it would be a great opportunity to take a deep dive to spotlight psoriatic arthritis, which has a huge impact on our community and affects an estimated 3% or 30% of people with psoriasis. So it's a really important topic to us. And putting the screen up again, because we do have additional information on our website about psoriatic arthritis. We have resources there highlighting our most recent report that just came out this week called Bearing It All, that looks at sexual and reproductive health for women plus who live with inflammatory arthritis, rheumatic, and psoriatic diseases, and really looks at the full life course of women plus who live with these conditions. So I wanted to point that out and welcome you to check out our site if you're not a member already, cpn-rcp.com, because there's a lot of great additional information to what you'll hear tonight, and this session again will be posted on our website along with all of our past webinars. So before I turn it over again to our speakers tonight, I've shared a little bit about us, and I'd love to get to know a little bit about our audience tonight. So we do have a couple of polling questions just to kind of orient us as to who we're joined with this evening. So please do share if you would like. Just how familiar are you with psoriatic arthritis? So very familiar, somewhat familiar, or not very familiar at all? Just give it a second as the poll loads. All right. Thank you. So it looks like you can see the results. We got somewhat familiar being the kind of majority here. So great to know. And I think that we're going to learn a lot. So I think there's going to be something for everyone here, which is great. And just next question is, do you see any of the following specialists? So we're lucky because we have perspectives from a dermatologist and a rheumatologist this evening. So we'd love to know just your experience with these specialists. So I'll launch that now. Okay, great. So it looks like we do have some experience across both with both specialists. So again, I think it'll be very interesting to the audience tonight to hear from both of these perspectives, depending on, again, who you're working with already. You'll be able to get some insights and information from both our experts. So thank you so much for sharing that information. I think it's really insightful for our speakers tonight to know where you're coming from. And with no further ado, I'm so grateful to our speakers this evening because we do have some fantastic expertise, and I'm really looking forward to hearing from their perspectives. As I mentioned, we're going to start off with Dr. Renita Ahluwalia, who is an expert dermatologist who can do some level setting for us about psoriasis. And about the dermatologist's role in psoriatic arthritis and supporting patients who may be experiencing this associated condition. So I will give you a little bit of a bio about Dr. Ahluwalia and then turn it over to her to get us started for tonight. So Dr. Renita Ahluwalia completed her undergraduate studies in her hometown of Winnipeg, earning both a BA and a Bachelor of Science from the University of Manitoba in 4 years. She then studied medicine at the University of Toronto, where she went on to complete residency training in dermatology in 2013, serving as chief resident during her final year. She's presented at national and international meetings and has been the recipient of numerous awards. As a former national public speaking champion, Dr. Ahluwalia uses her unique skill set to be a healthcare advocate and a credible source of knowledge to the public on a variety of dermatological issues. And I can speak from the patient community perspective that Dr. Ahluwalia is always very supportive of these types of educational events with us and is a fantastic resource for supporting members of our community. So we're very grateful to have you tonight, Dr. Ahluwalia, and I'll turn it over to you.
Thanks so much. It's my pleasure to be here. Psoriasis is one of the topics that I really like to discuss and that I really like to treat because we're able now to get such great results for patients. And at our center, we now have a psoriasis clinic where we're able to see these patients regularly. So if you are looking for a dermatologist, we would be happy to help you at our center. Next slide. I work with many of the Biologic companies. I'm a speaker and consultant for the ones listed below. Next slide. My office, my private office is the Canadian Dermatology Center. I also work at Women's College in Toronto Western Hospital, but my main office is the Canadian Dermatology Center, and we're a full-service dermatology and plastic surgery center, and we have a lot of specialized clinics, like I mentioned, including in psoriasis and other disorders of inflammation. Next slide. And that's just pictures of our new center. We've been open now for 2 years. Next slide. So this is kind of the overview of what I wanted to discuss today. Just to overview psoriasis, some of the causes, how we make the diagnosis, just talk a little bit about treatment options, and then of course, the star of the evening, the associated condition, PsA. So I just wanted to tell you a little bit about my thought process when I see patients and how I screen for PsA and how you can help me and your dermatologist identify your symptoms so we can get you the appropriate treatments and connect you with a rheumatologist if possible. Next slide. So let's talk a little bit about psoriasis. So as Antonella mentioned, the prevalence of psoriasis is around 2.5%, and it affects men and women, and the cumulative prevalence is increasing. And so that could be, to a lot of different factors, possibly due to population aging, population growth. Maybe we're recognizing psoriasis more and more people are identifying as having psoriasis. So it's a very common condition. Next slide. So here are some of the features that really characterize psoriasis. So it's a chronic condition. It's a recurring condition. So sometimes it can go away, but most of the time it does come back. And it's caused by inflammation, systemic inflammation. And you can see in the pictures over here, you have your patient with psoriasis and your control patient. And you can see there is inflammation in the psoriasis patient, in the aorta, in the liver, in the vasculature, in the joints, and in the skin. So we know that this is a disorder of inflammation. It's more than just the skin. There are a lot of comorbidities. And the other thing that's always important to point out is that it's not contagious. It can't be transmitted from one person to another. And although it seems intuitive to someone who's living with psoriasis or to a doctor, it's always something that, family members and people have concerns about. So it's an important thing to point out about this disease state. Next slide. So there are different types of psoriasis. They're just going to pop up over here. The most common is plaque psoriasis, which often affects the elbows and knees and other areas of the body. Gut-tape psoriasis often happens in younger patients, often after times of stress, most commonly after a strep infection. Erythrodermic psoriasis means that over 90% of your body surface area is covered with psoriasis and you're almost entirely red. Inverse psoriasis looks different and is often misdiagnosed because often the plaques look smooth and they're in the folds rather than elbows and knees. And then pustular psoriasis is a more rare form of psoriasis, often affecting the palms and soles, but a very serious form of pustular psoriasis can affect the whole body. Next slide. So plaque psoriasis, these are some great photos. It's the most frequent type, as I mentioned, 90% of cases. Lesions are often bilateral, they're often symmetrical, and patients complain of pain and itching quite commonly. Often the lesions have point bleeding when they're scratched, and we see this, every day, and these patients can range from very mild to very severe. Next slide. So the reason people develop these thick, scaly plaques is because usually the skin cells replace themselves every 28 days, but in plaque psoriasis, those skin cells are turning over very rapidly. So they're replacing themselves instead of every 28 days, every 3 to 5 days. And that increased skin cell turnover results in these scaly plaques and the inflamed skin. Next slide. So let's look at some of the causes. So there's 3 kind of interplaying factors that play a role. So genetic factors, so several genes have been identified that play a role. About 30% of patients who suffer from psoriasis have a first-degree relative with the disease. If both your parents have psoriasis, there is a 70 to 80% chance that you will have the disease. It's an immunological disease, which is T-cell centered, and there's many different parts of the immune system that play a role. And we've really started to understand them. And what's really neat is that we have very specific targeted therapies to target some of those interleukins that we know are elevated in psoriasis to help bring down the inflammation and help bring that skin cell turnover back to normal. And then there are, of course, environmental factors. So any injury to the skin produces psoriasis. So that's called the Kebner phenomenon. There are certain seasons that trigger people's psoriasis, stress, infections, medication, smoking, alcohol. All of those play a role in promoting inflammation. So having a healthy lifestyle and focusing on those aspects is always something I discuss with my patients too. Next slide. So let's talk a little bit about diagnosis and severity. So the diagnosis of psoriasis is not a difficult diagnosis in 99% of cases for a dermatologist, because it's almost exclusively a clinical diagnosis based on some of the factors that we've talked about. But assessment of disease severity is tricky, because a lot of it has to do with the subjective evaluation of how it impacts the psoriasis on an individual's quality of life. And, you know, some people can have what may appear to be mild psoriasis, not affecting a large body surface area, but it's having a huge psychosocial impact for them. And some people, you would think maybe it would have a larger psychosocial burden for them, and it doesn't. So I find that it's always very important for me to talk to my patients about their subjective evaluation of their disease. And then we also do some objective measurements, including their body surface area, their PsA score, which gives us a number taking into account the body surface that's involved, the different areas of the body, the thickness and the redness of the plaques. So that helps with the objective measures. And then the DLQI, or quality of life assessment, is something that I commonly use in my practice to help get a sense of the subjective evaluation on the quality of life. Next slide. So we've come so far in the treatment of psoriasis, and there's a lot of different things that play a role. The type of psoriasis, is it a more chronic type? What type of disease-free intervals do people have? What is the extent of the disease? What are their plans for pregnancy? Do they have other health problems? One of the things that I find challenging as a dermatologist is sometimes access to some of the treatments. So what kind of drug plan do they have? What kind of treatments can an individual afford? And also different people have different levels of comfort with different types of treatments. So just providing the education to my patients so that they can make the best decision for themselves. Next slide. So these are some questions that I always recommend that when you see a dermatologist, you talk to your doctor about, you know, what is the type of psoriasis you have? Where can I go to for information about the disease, about treatment options? What are the treatment options available? Because a lot of people haven't seen a dermatologist in a long time. They don't know about the classes of molecules that are available, both topically and injectables and orally. And what should their expectations be in terms of treatment? And I'll tell you now, with a lot of these newer systemic agents, the expectations are really high. And even people who are walking around with the worst cases of psoriasis are often clear or almost clear. And then it's also important to talk about side effects and benefits of treatment, and what the expectations are of how long it'll take to work, and can they expect to see sustained results. So those are important things to talk to your dermatologist about as well. Next slide. So there are three kind of major categories: topical agents, phototherapy, and systemic agents. So topical therapies are great for mild disease, and often we use them in combination even when patients are on other treatments. And the main classes that we use are listed below here, mainly steroids, often vitamin D analogs, combination products, combinations of retinoids and steroids together too. So there's a lot of good topicals out there. Next slide. And then, you know, the systemic agents, we have a lot of different options available now. There's pills, there's injections, there's infusions. And when someone has severe disease, or we're concerned about comorbidities like psoriatic arthritis, and we want to lower overall inflammation in the body, this is usually the approach we take. And the current standard treatments that have been older treatments are acitretin, cyclosporin, and methotrexate. There's a newer, smaller molecule called apremilast or Otezla that is also an oral systemic treatment that has been quite popular due to its safety profile. Next slide. And then phototherapy can be even kind of grouped in the systemic treatments because it does actually produce a systemic anti-inflammatory effect through inhibiting some of those interleukins, and it can slow the growth of skin cells. Next slide. And then, of course, there's the biologic therapies, and we have now more biologic therapies than ever on the market. The newer agents are the IL-17s and the IL-23s. And, these injections have revolutionized our expectations for psoriasis and have really allowed us to get a lot of patients clear or almost clear, and have had a huge impact on quality of life. And many of these agents are also approved for psoriatic arthritis. So whenever I see a patient and we're considering that they also have psoriatic arthritis, we sometimes pick an agent that has been approved for that as well too. And I've had really interesting cases where I've had patients who have psoriasis and they've gone off their biologic agent, and then they start complaining of joint symptoms and symptoms of psoriatic arthritis. So, the biologic was probably masking the presentation of that, and when coming off, the symptoms occurred. Next slide. So it's really important to be informed about your psoriasis and what's available, and find a doctor that you can communicate effectively with, and someone who's up to date and willing to provide you the options for all these different treatment options. Psoriasis, it's important to have realistic expectations, but those expectations are high now. This is a condition you'll have all your life, and you'll probably need some type of treatment. But these days, many of my patients, with injections 4 times a year, are forgetting that they even have a major concern. And it's always important to don't assume that there's nothing else you can do and it's something you just have to live with and suffer with, because there are a lot of different options, and it's about finding the right option for you in your life. Next slide. So let's talk a little bit about associated conditions. So as we mentioned earlier, and one of the key points to drive home is that psoriasis is not just about the skin, it's a disorder of inflammation. And all the conditions listed here are associated comorbidities. And one of the most common and most well-known comorbidities is, of course, psoriatic arthritis, which the focus for today's talk is. Next slide. So as Antonella also mentioned, psoriatic arthritis develops in up to 30% of patients with psoriasis. And it's the major comorbidity of psoriasis because it increases the likelihood of loss of general health and permanent disability, especially if initiation of treatment is delayed. And so that's why it's really important to recognize this early. And I feel privileged as a dermatologist to be able to help people with that. And your family doctors can help you with that too, because when it's recognized early, we can prevent a lot of damage. Next slide. So psoriatic arthritis has a similar prevalence in males and females. The majority of patients actually experience skin symptoms first. So about 75 to 84% have skin symptoms first. Arthritis precedes the skin symptoms in a smaller number of patients, 3 to 18%. It typically appears between age 30 and 50, but it can happen in anybody. And skin and joint symptoms appear simultaneously in 10 to 37% of patients. But most of the time, people have the skin symptoms before the psoriasis. Next slide. So there are different types of psoriatic arthritis. There's peripheral arthritis. There even nail disease is very common in patients with psoriatic arthritis. A lot of people have axial disease. A lot of patients have enthesitis, which is inflammation where the tendon or ligament attaches to the bone. And a lot of people have dactylitis where, you see those sausage digits, swollen digits. So those are often things I ask about and I look about when I'm examining a patient. Next slide. So this is why screening for psoriatic arthritis is so important. Nearly 52% of patients with psoriasis have joint pain without a diagnosis of PsA. And the average diagnostic delay for psoriatic arthritis is 5 years. So it's always important to take, a very practical approach with your dermatologist. And if you're having joint symptoms, bring it up. And I look for that in my patients. I look for those sausage digits when I examine them. I look for psoriasis in certain locations, like the nails is a predictor, the scalp is a predictor, the lower back is a predictor. I ask them about hot swollen joints. I ask them about morning stiffness. And those are kind of the practical things that I review. And if those are symptoms that you're having, those are things you should talk to the dermatologist about. Next slide. So let's just talk a little bit of classification. So on a day-to-day basis, I don't really do these things in my practice, but there are things I know about and that I keep in the back of my mind when I'm interviewing a patient. So the CASPAR classification criteria, I think Dr. Gladman's going to talk a little bit more about, but patients are assigned points based on the features listed below. So do they have current psoriasis? Do they have a personal history of psoriasis, a family history of psoriasis, the nail dystrophy, a negative rheumatoid factor, meaning that they likely don't have rheumatoid arthritis, current dactylitis or a history of dactylitis, and then radiological evidence of just juxtaarticular new bone formation. Next slide. So this is another tool. It's called the PEST screening questions. So although I don't typically administer this, these are questions that I have in the back of my mind that I know to ask patients who are having joint symptoms. And so there are things to think about. So do you have swollen joints? Has a doctor told you you have arthritis? Do your fingernails or toenails have holes or pits? Do you have pain in your heels? Because the heel, that Achilles is a major enthesitis site. Have you had a finger or toe that was completely swollen or painful for no apparent reason? So that's one of the great screens for dactylitis. Next slide. And then, additional screening tools that as a dermatologist, I don't often use, but it's important to know they exist. The TOPAS scores, the 12-item questionnaire, that includes pictures of psoriasis and nail lesions, and it's designed as a screening tool for psoriatic arthritis. Next slide. And that is the end. So now, if you have any other additional questions for me, please do feel free to email me or email Antonella, and she will pass those along to me. And if you're looking for a dermatologist, we're a great group at the Canadian Dermatology Center, and we love treating psoriasis, so we'd be happy to see you.
Thank you so much, Dr. Ahluwalia, for taking a huge topic and putting in a very short segment to get us going this evening. We greatly appreciate it. And as I mentioned, Dr. Ahluwalia, though she can't stay for Q&A later today, if you have any questions about, from a dermatologist perspective or about psoriasis, we're happy to pass that along and get questions answered to you after the session by email. So greatly appreciate your time and your
Thank you so much. Have a great evening, everyone. Bye.
Thank you. So I am so excited to turn the presentation over to our guest speaker this evening, a renowned researcher in this space. We're very grateful to have Dr. Gladman with us tonight. As I introduce her, I do want to invite you, Dr. Gladman, to try to share your screen if you're able to. And then if not, I'm happy to pull up the slides on your behalf. but I will just for, I'm sure many people on this call have heard of you or have if they live with psoriatic arthritis may have read your research, but I am going to give a little bit of a background to introduce you to all of our audience tonight. So Dr. Dafna Gladman is professor of medicine at the University of Toronto in Canada. She's a senior rheumatologist, deputy director of the Center for Prognosis Studies in the Rheumatic Diseases, director of the Psoriatic Arthritis Program, co-director of the University of Toronto Lupus Clinic, and a senior scientist at the Schroeder Arthritis Institute, Krembil Research Institute at Toronto Western Hospital. Dr. Gladman helped establish the Group for the Research and Assessment of Psoriasis and Psoriatic Arthritis and was its first president from 2006 to 2009. In 2007, Dr. Gladman established the International Psoriasis and Arthritis Research Team, so IPART. Dr. Gladman is a co-principal investigator, executive committee member, and incumbent treasurer of the Spondyloarthritis Research Consortium of Canada, a research program that aims to achieve significant improvement in outcomes for Canadians with spondyloarthritis. Dr. Gladman's research program includes clinical and laboratory research in both psoriatic arthritis and systemic lupus erythematosus. She has authored 887 peer-reviewed publications, 141 chapters and invited publications, 2 books, and has edited 3 other books. Dr. Gladman received the Mentor of the Year Award from the Royal College of Physicians and Surgeons of Canada, was awarded the Carol Nachman Prize for Innovative Research in Inflammatory Arthritis, and the Distinguished Clinical Investigator Award from the American College of Rheumatology. She's the Master of the American College of Rheumatology and the Canadian Rheumatology Association. And I'm again grateful to have you join us, and also want to add that you also make time to do presentations like this for patient organizations. So thank you very much for that. And I just want to check in and see if you're able to share your screen. Otherwise, I will be pleased.
I'm trying.
Okay.
I don't think it's working. Can you see it?
I can't see it yet.
Okay,
so
never mind. Let's go.
Let me do that.
Screen.
Yes.
I just need to try and get out of my. What's happening? I can't do anything now. 1 second.
Okay.
All right, I'm going to close my screen.
Okay.
And let's okay, here we go. That's fine.
Fantastic. Thank you.
All right, so this is what we're talking about. Next slide, please. Okay, so the objectives for tonight are to review current concept in psoriatic arthritis, which will cover signs and symptoms, the causes, impact of the disease on an individual, family, and society, touch on treatments, and then talk about supports for living well with psoriatic arthritis. Next, please. Now, the definition of psoriatic arthritis, it's an inflammatory arthritis that's associated with psoriasis, and it's usually negative for a test for rheumatoid factor. This is a test that was discovered in 1948 and helped the medical community at the time distinguish between rheumatoid arthritis and psoriatic arthritis because rheumatoid arthritis was positive. Next, please. And of course, these are the skin lesions of psoriasis. Next, please. Now, let's talk a little bit about the joints. So on the left-hand side, we have a normal joint. And what you can see is there are 2 bones. Unfortunately, I can't use the pointer, but you can see the bones. And you can see that there is cartilage, which is right underneath or on top of the bone. And then the black line, it's a synovium. That's the special tissue of the joint. And then we have the muscle, which is right there. And the muscle is attached to the bone through a ligament. Okay, so now if we go into the right-hand side where we're looking at an inflamed joint, you can see that the synovium, that's the tissue that's specialized to the joint, when it gets inflamed, it proliferates, it grows. And when it grows, it actually can go into the bone and cause what we call an erosion. It's like having a bite out of the bone. At the same time, the insertion of the tendon into the bone can also get inflamed, and we call that enthesitis. And we can have tendinitis. The tendon itself can get inflamed. And so there are a number of things that happen. And as the synovium proliferates, as it grows, it allows fluid to accumulate in the joint. So often our patients present with a swollen knee or a swollen ankle or a swollen finger or swollen specific joint in the finger. And that tells us that there's inflammation in that joint. Next, please. So when we're looking at inflammatory arthritis, so first of all, I should say that there are two kinds of arthritis. There's an inflammatory arthritis, and I put a red in there because we consider it like a fire in the joint. But there's also non-inflammatory form of arthritis. And somebody had put a question in, what is the difference between psoriatic arthritis and osteoarthritis? Osteoarthritis is non-inflammatory. It's painful, but the pain usually comes when you use the joint, not when you're resting. It actually gets better with rest. Inflammatory arthritis is associated with tenderness, swelling, limitation of movement, and it usually gets better with activity and gets worse with rest. So most people present with pain in the morning and stiffness, and it gets better as they move around. So when we're looking at inflammatory arthritis, we recognize that there are three major groups. One is a seropositive, as I mentioned earlier, that's a rheumatoid factor, and that includes rheumatoid arthritis. And one is the seronegative, which includes the psoriatic arthritis. And then there can be infectious, which is like having an infection in the joint. Next, please. And so one of the biggest issues for patients and doctors is how do we differentiate psoriatic arthritis from rheumatoid arthritis? Interestingly, psoriatic arthritis is not quite as painful as rheumatoid arthritis. Now you'd think maybe it's a good thing, you don't have a lot of pain. Not so, because what happens is damage can occur in the joint without the patient even noticing it. So we have a number of patients that come to us with deformed joints and they don't remember having pain. The rheumatoid factor test, as I said, is usually negative. It also affects different groups of joints, especially the differences between the joints at the ends of the fingers and toes. Now, some of these joints can get affected with osteoarthritis, but as I mentioned, osteoarthritis is not inflammatory. Moreover, in psoriatic arthritis, the joints of the spine, the neck, the middle of the back, the lower back can get affected, and the sacroiliac joints, which are the joints in the pelvis. So that's another thing that helps us differentiate. As Dr. Ahluwalia mentioned earlier, patients with psoriatic arthritis get dactylitis or sausage digit. And I'm going to show you some pictures of that in a minute. And I already mentioned the enthesitis, the inflammation of the tendon attachments. And also the fact that the patient presents with inflammatory arthritis and they have a history of psoriasis of either the skin or the nails, or they may have a family history of psoriasis in a first or second degree relative, or they have psoriasis when we see them. So that certainly is helpful. Next slide, please. So here are some pictures, or actually drawings that were done actually by a rheumatologist, Dr. Mall, in England. And you can see what the sausage figure looks like. It's the shaded area. You can see the swollen ends of the joints of the fingers, and you can see where the Achilles tendon is affected by this enthesitis. Next slide, please. So who gets psoriatic arthritis? Well, it's usually people with psoriasis. So as was mentioned earlier, a large proportion of the patients with psoriatic arthritis would have presented with psoriasis either before or at the same time. In our series, only about 12% did not have any evidence of psoriasis before they were diagnosed. But it's interesting because there's a study that was done in the Netherlands where they showed that 2 patients were referred to 15 clinicians, and several of the clinicians did not make the right diagnosis because they didn't ask about psoriasis and they didn't get the patient undressed. So I have a patient who actually was seen in my office by a resident first, and the resident didn't tell me anything about psoriasis. So I looked at the patient and I said to her, "So where is your psoriasis?" And she says to me, "How did you know? I never told anybody." But the giveaway to me was she had dactylitis, that swollen digit. That was a giveaway that she had psoriasis. So the fact that some people are diagnosed with the arthritis before the psoriasis may be a little suspect, because if nobody had asked them or examined them, they may not have known. So anywhere between 7 and 42% of psoriasis sufferers have been reported to have psoriatic arthritis, depending on where the study was done. Using a systematic approach, it's 30%. Men and women have equal opportunity to get this disease, as opposed to rheumatoid arthritis, which is 3/4 women. And the psoriatic arthritis can occur at any age, but the peak age is 38. And as I said, it often occurs in people with a family history of psoriatic arthritis. So they are at a higher risk, and we'll talk about causes in a minute. Next, please. So the patterns of psoriatic arthritis, we've already heard from Dr. Ahluwalia, but I'll just repeat it very quickly. There is a distal predominant, which the joints at the end of the fingers and toes. There's an oligoarticular, which is 4 or less joints. So only a knee, wrist, and finger may be involved, or only 2 wrists and nothing else, or only a couple of toes and nothing else. Or it can be what we call polyarticular, where 5 or more joints are affected. And in this case, it looks a little bit like rheumatoid arthritis, although it's mostly not as symmetrical as rheumatoid arthritis tends to be. And then patients get spondylitis, which is inflammation of the back joints. And one of the things that have been recognized about psoriatic arthritis is a very unique feature, which fortunately does not very often, is arthritis mutilans, which is a very destructive form of arthritis. Fortunately, it only occurs in 5% of the patients. Next, please. So here are examples of the psoriatic arthritis patterns. You can see the distal disease where the arrow is, and the hands in the middle are a reflection of a polyarthritis. The one thing that we can recognize as typical for psoriatic arthritis is if you look at the middle finger on the right hand, you can see that it's shortened. And again, this is a typical picture of psoriatic arthritis. The other fingers look fine, and this finger is shortened. And then if you look at the hands on the right-hand side, you can see that the index finger on the right is very much shortened. And in fact, it turns out that the bones at the end of the finger have melted away. The one on the left bottom is an oligoarthritis, only the 3rd finger in the middle, the middle finger on the left. You can see that it's a little bit red and swollen right there in the middle where the arrow is. And then on the one on the right, we can see that there are quite a number of joints that are inflamed. And you see the psoriasis in a number of these fingers occurring even close to where the distal joints, the end joints are. Next, please. And these are some other features. So I said I was going to show you the dactylitis. So you can see in the top 2 fingers on the left, these reflect dactylitis. The one on the left hand, it's the middle finger, and you can see that it's quite swollen. But this finger no longer hurts that person, and it remains swollen after the acute inflammation. The one on the right side, you can see the index finger is swollen, And you can see the redness and the swelling over the individual joints, the distal joint and the middle joint. And there's a little bit of redness even on the knuckle, so that these are acute versus chronic. In other words, acute happening really recently and still being very painful and inflamed. And the chronic is something that did not get treated on time. And by the time the patient realized that the finger was swollen, it didn't hurt anymore and there was nothing we could do about it. And then of course, the psoriasis we talked about earlier. And then you can see the enthesitis. So the picture of the ankle shows the redness where the Achilles tendon attaches into the ankle bone. And the X-ray actually shows that there is a little bit of extra bone where if you move over a little bit more. Yeah, you can see right there, you can see a little bit more. Right there, you can see that it's a spur. And that is also associated with enthesitis. And then, of course, the nail lesions, which we can see on the bottom right two fingers. The first one shows onycholysis, which is lysis of the nail. And the one on the right shows the nail pits. It looks like somebody's taken a pin and just went through the nail, causing little holes. Next, please. Now, the important thing about the nail lesions, as Dr. Ahluwalia mentioned, is that nail lesions are one of the obvious clinical manifestations that identify patients that develop psoriatic arthritis. So our dermatologists, as you could hear, already recognize the fact that if a patient has nail lesions, they have to be on alert for the possibility of having psoriatic arthritis. Now, this set of pictures shows you the spondyloarthritis, the inflammatory arthritis of the back. And we can see from the clinical picture with the man trying to touch his toes, he can't. Because if you look at the middle X-ray, you can see that there is bone going from one vertebra to the other. And those are typical pictures of psoriatic arthritis. Next, please. So when we look at the patterns of psoriatic arthritis in terms of what I've shown you, a large proportion, 42%, presented with oligoarticular disease, but over time, they can become polyarticular. The back alone occurs in a very small proportion, 5% maybe. The distal joints only occurs probably in less than 17%, and the arthritis mutilans in this particular study was only 1%, which is very good, but it's usually about 5%. Next, please. Now, what are the causes of psoriatic arthritis? Next, please. So the bottom line is we really don't know for sure, but there are a number of possible causes. Infection and trauma, injury. We have demonstrated from a study that we've done on patients with psoriasis who don't have arthritis and compared them to our patients with psoriatic arthritis. It turns out that patients with psoriatic arthritis were more likely to have had an infection that needed to be treated with antibiotics prior to the onset of arthritis, or they may have had an injury of some sort. And a group from England actually showed the same kind of thing. The psoriasis may have something to do with it. Why does it occur in patients with psoriasis? And we know that 30% of patients with psoriasis get it. But the only question is, why don't the other ones get it? So that's a question that we're trying to address. So we feel that there is a hereditary predisposition. And Dr. Ahluwalia pointed out also that in addition to the genetics, the hereditary factors, there's also immunological factors. Now, whether the immunological factors are totally separate or whether they're related to the hereditary factors, we still don't know, because there is a relationship between certain types of genetic markers and certain types of immune responses. So we're still scratching our heads, but stay tuned. Next slide, please. Because there will, over the next 5 years, we'll probably have a lot more information. So this is a little bit of information about the genetics. So we know that there are markers that are present on our cells. There are HLA markers, which occur more frequently among patients with psoriasis than the general population. Many of these also occur in psoriatic arthritis, but some of the markers are different between patients with psoriatic arthritis and those with psoriasis only. So the picture is actually of a DNA, and that's what we do. We isolate DNA and we check the markers through DNA analysis. And so we know that for a fact now, but we know that those are not the only cause, because not everybody has these markers, and not everybody that has the markers develop disease. So we still have to figure out some more relationships here. Next, please. And so some of the genetic markers identify patients who will develop disease progression. So for example, a patient presents with some inflammation, and then they go on to develop destructive joint disease, and it turns out that some of the markers can identify those. And these markers are stronger than the clinical features at presentation. Next, please. So we recognize the signs and symptoms, and we're still struggling with the causes, but that doesn't mean that we can't treat the patients, which we'll talk about shortly. But what's the impact of the disease on the individual, and of course their family and society at large? So let's try and dissect that. Next slide, please. So what happens to people with psoriatic arthritis? Well, quite variable. Some patients may only have very mild, short-lived symptoms. So some have symptoms, they last a certain period of time, they get treated, and then they get better, and it never comes back to haunt them. Very lucky. Some patients may actually have a remission. They've had bad disease, and after they were treated, they totally do not have any signs or symptoms of arthritis. And we've actually defined, in our series, we defined remission as not having anything. No pain, no swelling, no back pain, no psoriasis. And we identified that at one point in time, 18% can achieve that, and 9% actually maintain that for at least 1 year. On the other hand, we know that about 50% of the patients develop erosions over time. In fact, probably more. It's 50% of the patients develop erosions by the time they present, but a much larger number will develop erosions over time. We, in fact, have only identified 12% of our patients that did not have an erosion even after 10 years of follow-up. And then with time, the joints can damage and lose their function. So that's really what we're trying to avoid. Next, please. So what we do know is the degree of the joint inflammation predicts joint damage. And inflammation in a particular joint, in other words, if this joint is inflamed, this joint is likely to damage. So it really means that inflammation begets damage. We know that more damage, if a patient already has damage, they're more likely to have more damage. And more damage is associated with reduced function. Inflammation and damage predict disability. So it's clear that what we have to do is turn off the inflammation. And as Dr. Ahluwalia mentioned earlier, one of the reasons that we're so adamant now about trying to make an early diagnosis is the earlier we diagnose, the earlier we can treat, the more likely we are to prevent this impact. Next, please. Now, the damage that can occur is as follows. The cartilage in the bone can be destroyed. I showed you in the cartoon of the joint that the inflammation, the inflamed synovium bites into the bone, and that's not recoverable. The joints become deformed and have less range of movement. And as the movement reduces, the joints actually fuse, they become ankylosed, and then they're totally useless. And some joints actually became what we call flail, like they're totally loose. And if we look at the next slide, we can see some of these pictures. So the top left-hand picture demonstrate joints that are fused. So this person was actually an engineer. He was an Olivetti typewriter engineer. So most people probably don't even know what that is, but that's what we used to use before computers. And he couldn't be an engineer anymore because he could not move his hands. And if you look at the one on the bottom left, you can see that the left hand looks worse than the right hand. And that's very typical. Psoriatic arthritis tends to be asymmetric. Now, the feet on the top, you can see that all the toes are very flail. And this person can't walk around without shoes. And the hands on the bottom right are also very flail. And this person can no longer knit or sew because of this destruction of her joints. Next, please. Oh, and this, of course, is the worst kind of damage that we've ever seen. This, again, this guy was an engineer as well. And because he was an engineer, he made the photographer take the next two pictures, this one and the next one. And what you can see is the one in the middle, it's the finger as it is without touching it. It measures about 2 centimeters. And then he made the photographer pull up on the finger, and he could telescope it up to 5 centimeters. And that's, again, a typical picture that used to be describing psoriatic arthritis in the 1950s and 60s. And this is the utmost arthritis mutilans. We don't want to see that. Fortunately, we have not seen this for a very long time now. Next, please. And here you can see, I showed you earlier the hands on the left, and now you can see the x-rays that show that there's no bone in there. Next, please. And the same here. Next, please. Okay. So now patients actually suffer from pain. As I mentioned, they have deformities and limitation of function, but they may also have disrupted sleep, and they may suffer from fatigue, which could be because of disrupted sleep, but it could be part of the inflammatory process. So it's really a very difficult thing for patients to suffer. Next, please. And in addition to the direct effect of the joint inflammation, there is a higher risk of cardiovascular disease, diabetes, metabolic syndrome, gout, as well as anxiety and depression. Importantly, all are related to the degree of inflammation. So again, I think you get the point that it's important to turn off the inflammation. Next, please. Now, what's the effect on the family? It's very difficult for a spouse or children to, first of all, watch their loved one suffer with this condition. And sometimes they need a lot of help because they can't do a lot of things for themselves. It therefore has an effect on relationships, and it has an effect on society because people cannot work and they can't contribute as much as they should and could if they didn't have this condition. Again, diagnosing and treating early with proper medications may actually avert all of those issues. Next, please. And so what do we do? What are the treatments that are available to us? So first, next slide, please. I want to just tell you, what are the goals of treatment? So first of all, from the patient's point of view, we want to reduce the pain and discomfort. And to do that, we can use pain medications and anti-inflammatory drugs, non-steroidal anti-inflammatory drugs, like we used to use aspirin, now we use naproxen, we use ibuprofen, we can use Celebrex. There are a number of anti-inflammatory medications. But the main aim is to prevent damage to the joints. And to do that, we need to identify and treat patients early. And we'll talk about how we can do that. And then we want to maintain function and mobility. And we can do that by, 1, controlling inflammation, and 2, by providing physiotherapy and exercises. And we want to improve, or at least not worsen, the psoriasis. So as Dr. Ahluwalia mentioned earlier, we use medications that work for both the skin and the joints. And of course, we want to prevent those comorbidities that I mentioned. We need to turn off inflammation. Next, please. So here's the pyramid of treatment that we have. And that's generally used for inflammatory arthritis in general, but I'll point out the specifics for psoriatic arthritis. So I already mentioned that we use education, rest, exercise, and pain medications, and the non-steroidal anti-inflammatory medications. Our next step is usually what we call conventional disease-modifying anti-rheumatic drugs. And they include methotrexate, leflunomide or Reva, azathioprine or Imuran, sulfasalazine, and cyclosporine. So methotrexate works better for skin than joints, but it also works for joints a little bit. Leflunomide works better for joints than skin, works for skin a little bit. Imuran works a little bit for the joints, not as good for the skin. Sulfasalazine, a little bit of both. And cyclosporine works better for the skin than it does for the joints, but it also works for the joints a little bit. But these medications have not been shown to modify the disease course. Even if they do control the inflammation, they may not control it well enough to prevent damage from progressing. And so the big breakthrough that occurred in psoriatic arthritis was in 2000, when the biologic agents became available. And the first agent that became available was etanercept or Enbrel, and it was a tumor necrosis factor or TNF inhibitor. And we've had, as Dr. Ahluwalia showed you earlier, there are now 5 different anti-TNF agents. We have a number of IL-17 inhibitors. Some of them have been proven effective in psoriatic arthritis as well as psoriasis, and some of them have not yet been approved for psoriatic arthritis, but probably will be in the near future. The IL-23 agents, guselkumab or Tremfya, has been proven effective for both. And we have another agent called abatacept, or it's a CTLA-4 Ig, which works for the joints and a little bit for the skin, but it doesn't work as well for the joints as the other 3 groups that I already mentioned. And then we have, and those are all injectable, by the way. And then we have what we call small molecules, which are pills. So one of them is a PDE4 inhibitor, which we call it apremilast, but it's marketed as Otezla. And then we have JAK inhibitors, Janus kinase. It's an enzyme that's necessary in the inflammatory response. This is an inhibitor, and there are 2 of them on the market at the moment. One is tofacitinib or Xelance, and the other one is upadacitinib or Rinvoq. They both work reasonably well for the joints. They don't work as well for the skin as the injectable biologics, but they're getting close. And so for people that don't like to get injections, those are very good options. And there are a number of other drugs that are currently under investigation. What we do in the joints is, if the joint is very swollen, we can put a shot of cortisone in there. And obviously, if the joints are destroyed, we can use surgery to correct them. So this is basically the approach to the treatment of psoriatic arthritis. Next slide, please. Now we need to know about the side effects. As it turns out, when we look at the novel therapies, the side effects are not that terrible. With the anti-TNF agents, injection site reactions or infusion reactions, if they're getting it by infusion, are the commonest side effects, and most patients don't need to stop the medication for that. We are always concerned about increased risk of infection because these are biologic agents that that are inhibiting some of the normal response of the body. And so there can be some activation of tuberculosis, for example. So we now know that we have to check patients for TB before we consider using the medication. And if there's any evidence of exposure to TB in the past, we refer patients to infectious disease specialists, and they sometimes elect to treat the patient first before we can use a biologic agent. There are a few cases that have been described where they get a picture like demyelination, like some issue with a neurological issue, and that fortunately is very rare. So this is the TNF agents. The IL-17 agents have injection site reactions, and in terms of infections, it's candida, it's yeast infections that we most worry about, although most of them are very mild and can be easily treated. But that is not surprising at all, because one of the mechanisms of IL-17 is that it controls yeast. And if you give it an inhibitor, it allows the yeast to proliferate. So this was not an unexpected side effect. And as I say, we can address that. The JAK inhibitors, there is a concern about increasing cholesterol and increasing lipids. And in terms of infection, it's the shingles. And so we now know that we need to get our patients vaccinated against shingles before we use a JAK inhibitor. With the CTLA-4 Ig, only infusion reactions. It actually doesn't have a lot of concerns in terms of infection. On the other hand, it's not as effective. And with the IL-23 inhibitors, it's mostly nasopharyngitis, which again, it's a very common situation. But so overall, relatively safe, as opposed to methotrexate, which can affect the liver, and leflunomide, which can lead to high blood pressure, etc. So overall, these drugs are relatively safe. Next, please. And so how do we identify patients with psoriatic arthritis early? So we ask the patients with psoriasis if they have joint pain, and we are educating our dermatology and family medicine colleagues to do that. And then we can use the CASPAR criteria, or we can use a screening questionnaire. And Dr. Ahluwalia dealt with that earlier, but I'll briefly go over the CASPAR criteria next. So you've seen them before. This is just a little bit different way of presenting it. But basically, there are 6 possible things. There are 5 possible things, and you can get 6 points, because you can get 2 points if you have current psoriasis. And these are very specific and very sensitive, which is very important when you use classification criteria. However, one of the problems with the criteria is that one has to know that a patient has an inflammatory musculoskeletal disease. In other words, either arthritis, spondylitis, or enthesitis. And it's only rheumatologists that are trained to identify those. So it really doesn't help the people that see the patient first. On the other hand, next slide, administering a screening questionnaire, which the patient responds to, is much better. And this is the topaz that Dr. Ahluwalia mentioned earlier, that shows the pictures. And you can see there's a picture of the psoriasis, and there's a picture of the nail lesions, and there's a picture of the arthritis and the dactylitis, and it asks about back pain. So we find this questionnaire to be very sensitive and specific as well, and it works in a general medicine clinic or in the psoriasis clinic. So it identifies patients not just because they have psoriasis already, but also if they don't have psoriasis. Next, please. And then we have some other things. We talked about the clinical features earlier, the extent of psoriasis and the site of psoriasis and the nail lesions. But we know from a laboratory point of view, one of the genetic markers, the HLA-B27 that I mentioned earlier, and then there's an increase of an enzyme called MMP3 and an increase of C-reactive protein, which is a measure of inflammation, which occurs more commonly in psoriatic arthritis than psoriasis. And these can identify patients that have psoriatic arthritis. Next, please. And the other thing that we are now looking at is is the role of ultrasound. So this is a study that was done in Italy, where they look at the thickness of the enthesis, which is, I showed you earlier, it's the insertion of the tendon into the bone. And what they found was that people with psoriasis had thicker enthesis than people without psoriasis. And the next slide will show that when they follow people, next slide, please. When they follow people over 2 years, they found that 10% of the people with psoriasis that had a positive ultrasound progressed to have psoriatic arthritis. Next, please. So it may be something that will be usable, but it's not something that a dermatologist is going to do in their office. So what can we do to help people that live with psoriatic arthritis? Next, please. So there is the Canadian Psoriasis Network that you've heard about, and it's helping people to at least identify where to get help and what kind of help they can get. There's also the Canadian Alliance of Psoriasis Patients. There's the National Psoriasis Foundation in the United States and the Arthritis Society of Canada. And they all have support systems that are available to people with psoriatic arthritis. And they all have websites. If you put the term into a web engine, you'll find how to get through to them. Next, please. So we've covered the signs and symptoms of psoriatic arthritis, what we know about the causes, the impact of the disease on the individual, family, and society. We touched on the kind of treatments that we have and what supports for living well with psoriatic arthritis are available. And next slide, please. I would like to thank you all for listening, and we're open for questions.
Great. Thank you so much, Dr. Gladman. We do have quite a few questions that have come in. So I will start with one here. So I'll ask the question, how common is it for someone with psoriasis to have both psoriatic and rheumatoid arthritis? Negative RH, but positive CCP.
Okay, so the truth of the matter is, one can have both seropositive rheumatoid arthritis and psoriatic arthritis, because by chance alone, 1% of the general population has rheumatoid arthritis, and almost 1%, if 30% of patients with psoriasis have arthritis, and we have 1 to 3% of patients with psoriasis in the population, then about 1% of the population will have psoriatic arthritis. So by chance alone, 1 in 10,000 people could have psoriatic arthritis and rheumatoid arthritis. And I keep telling people, I've already seen mine, so I don't expect to see another one. Now, can a person have seronegative rheumatoid arthritis and psoriatic arthritis? I would say they probably have psoriatic arthritis.
Thank you so much for that. I'm going to go to another question directed at you. There's a few others that I'll get to about the presentation. I've had psoriasis since I was a teenager. Since a year ago, I've developed pain in my joints. So this person went to a dermatologist and he sent them to a rheumatologist. And the rheumatologist told me, you have to wait until you get worse. You're not bad enough to get treated by me. Is this correct? This person is getting desperate because the pain is getting worse and their back is killing them.
So,
what do you think that means?
There's no such thing as being bad enough. We want to diagnose it before it gets bad, right? We want to treat it before it gets bad. So I don't think we want to talk about bad enough. However, there is some truth in the statement, depending on what the goal is. If the goal is to put a person on a biologic agent, in most jurisdictions, we are restricted in what we can use and in when we can use the medication. So for example, in Ontario, which is where I practice, if a patient does not have 5 swollen joints, I cannot give them a biologic agent. And sometimes what we do is if they have bad skin, we ask the dermatologist to put them on a biologic for the skin, and that works for both. But there are other medications that a person could use to control their arthritis before we go to a biologic agent. We have anti-inflammatory medications. We have injections into the joint if there's only one or two joints that are a problem. We have the methotrexate, we have the sulfasalazine, so we certainly can do something. But I don't think that we should accept that one is not bad enough to be treated, because the answer should be, I don't want to be bad enough.
Very good. That's a good takeaway for tonight, for sure. Another question, for JAK use in patients and pre-medicating to prevent shingles. So I guess the shingles vaccine in advance.
Yeah, it's not pre-medication. It's really doing a vaccination.
Exactly. And
just like we're doing now for COVID-19, we're doing vaccinations to prevent getting the disease. So we do now. There are two kinds of vaccination for shingles. Mm-hmm. There's one that's a live attenuated vaccine. Mm-hmm. And there's another one that's not live, the Shingrix. So the recommendations are to get the Shingrix because it has a much higher efficacy. So we want to use that.
And is the other point of the question, is there an age criteria to receive the shingles vaccine?
So there is an age criteria to receive the shingles vaccine from the government. Mm-hmm. However, some of the companies will cover the vaccine for patients who are going on these drugs.
Okay. Okay.
So never give up.
Good. I know. Get your rheumatologist.
Always
advocate.
ways to get around the facts.
Okay. Yes, we need doctors that think like this.
You just need an advocate.
Exactly. And you pointed out some good patient organizations. So we're here. We get a lot of questions around these types of things for sure. Yes. And on that note, I want to point out, somebody mentioned the Canadian Spondylitis Association, definitely another great partner.
Oh, yes, I forgot to put them in. That's absolutely correct. I should put that into the slide.
Absolutely. And also the Canadian Arthritis Patient Alliance is a group we work with closely and do a lot of great work. So just remembering to mention them. Another question actually about, the getting around things. Do you think that the high cost of biologics leads to patients having to stay on methotrexate rather than being able to have the newer drugs? And again, whatever you can comment.
Yeah, so I mean, I don't have to think, it's a fact. Okay. It is a problem because people that are not covered by either insurance or the government insurance can't afford to get these medications. And that's one of the biggest frustration that we have as physicians, is we know what to do, but we can't do it. So sometimes we actually put patients on drug trials, which allows them access to a new medication. And in many of these trials, patients can stay on for a prolonged period of time until the government approves the drug and maybe they get approved. But it is a big problem. It is a very big problem. So we now have a series of drugs that are called biosimilars that are very similar to the originator drugs. So for example, there's several that are for etanercept, and there are a couple now for Humira, for adalimumab. So these are cheaper, and the government is ready to use them government is much more ready to use them. The only problem is that for an individual patient, if they're not covered, they're still not that cheap, because they're several $1,000s a year. And people that can't afford insurance definitely can't afford to pay for a drug that that amount of money. So it is really a big frustration. Mm-hmm.
Yeah, and I think the follow-up here was
something to be said for universal drug plan.
Yeah, exactly. I think yeah.
I see that there are two questions in French.
There are, and you know what? You answered one because you talked a little bit about the genetic component.
Yeah, so I hope that the gene that I identified as HLA-B27, it's the one that definitely distinguishes between psoriasis and psoriatic arthritis. But There are a number of other genes that we're working on at the moment, but they're not yet open for prime time.
We'll have you back live.
Yeah, well, I keep saying to people, stay tuned.
Exactly. Yes, we will. And then the other French language question was, are there Quebecois dermatologists associated with our center? And I think that might be a question that I can say there are, of course, depending on location, dermatologists, depending on like wait lists really depend on the individual clinic. The Canadian Dermatologist Association has a Find a Dermatologist tool on their website. That you can put in your postal code and it will show you in your vicinity who's around. If you have trouble, again, patient organizations, the Canadian Psoriasis Network, this is part of why we're here. So you can always get in contact too if you're struggling to access care, and we can help navigate if we are able to. So those are a couple of the French ones. And then we do have another question. There are a lot of questions here, so I'm going to, try to get to all of them, but we'll keep going as much as we can here. At what point should a person get a referral to a rheumatologist from a dermatologist? Dr. Gladman, if you can speak to that.
So certainly if a patient has joint pain, they should see a rheumatologist. Now, remember that not every single person that has joint pain, even with psoriasis, has psoriatic arthritis, because there are lots of other forms of arthritis. And we already covered osteoarthritis is actually a much more common form of arthritis. And it occurs in older people, although I must admit, I'm seeing it in younger people. I always used to think of osteoarthritis occurring after the age of 60, but now I'm seeing it in 40-year-olds, which is very disturbing. But the fact of the matter is, at least get a rheumatologist to make the correct diagnosis. Mm-hmm. So I think that a patient with psoriasis who has joint pain deserves to be seen by a rheumatologist, at least for an initial consultation, to define what kind of arthritis they have.
Great. Thank you so much.
Or if it is arthritis, sometimes you can have joint pain that's not related to true arthritis.
Exactly. Hence the need for a proper assessment. Okay, let's see. There's a couple of questions about COVID infection and PsA patients. I know this is a whole topic on its own, probably. But how does COVID infection affect PsA patients? It's just one part of the question. And then someone else asked, for those of us on biologics and double vaccinated for COVID-19, apparently now we're being advised to get a third vaccine. How do we go about doing this? And is a third vaccine different than a booster? I'm sure you could.
No, I mean, I can answer it because as it happens, I actually sit on the COVID-19 task force of the National Psoriasis Foundation because I sit on their medical board. So the answer to the first question, how does COVID-19 affect psoriatic arthritis? It's a very good question. So far, we don't think that COVID has made the psoriasis or psoriatic arthritis worse. Which we haven't heard that patients who get COVID actually aggravate their psoriasis or psoriatic arthritis. However, the number of patients, we don't actually know how many patients with psoriasis and psoriatic arthritis have been affected. There is a study going on in New York where they're actually questioning all of their patients in their psoriasis center. And we actually, I will know better tomorrow morning because I'm talking to my student who's been working on it on the summer, we administered a questionnaire, to some of our patients to find out what's happened to them during COVID. So we'll have an idea of how many people have actually had COVID and whether their arthritis or psoriasis got worse during the infection. But the impression that we have at the moment, and that's what the CDC, the Center for Disease Control in the United States, in their records, they have not come across worsening of psoriasis or psoriatic arthritis by COVID. Now, the second question about the third or booster shot, by the way, the third shot is a booster shot. And so the recommendations are for people that are taking immunosuppressive medications to get the booster shot. it's very difficult to know which drug should be included. But if the government is including biologics, I would certainly get it. In fact, I want to get one myself. So far, I'm not in the category, so I can't get it, but I'm waiting to get one.
Well, now that you say that, I want to get one too.
Yeah. No, I mean, but the recommendations are, see, the concern is that even in healthy individuals, there is a waning of the response over time. And we know it happens. I mean, look, we have to get the flu shots every year because that happens. So we knew that that was going to happen. We wanted to get the infection under control, the pandemic under control. But obviously, because there's still so many people around the world that are not vaccinated, we haven't achieved that yet. And now we have to keep going for a third round because we just aren't there. But people that have certain conditions like transplant, cancer people that are getting chemotherapy, or inflammatory disease people that have immune-mediated diseases may not have produced the same degree of response to the vaccine, and therefore it may wane in them a little bit faster. So the recommendations are, if you've had the original more than 5-6 months, they say you can take it even within 2 months, but 5-6 months for sure, people should get a booster. So those people that are taking immunosuppressive medications are eligible and should probably try to get them.
Thank you. I'm going to wrap up questions to you with one last one, and then I'm just, to respect time for everybody, especially for you, our speaker, we will wrap up. But the last question that I'll pose to you, Dr. Gladman, I'll preface it by saying, again, this is not individual advice, like as the host, and I'm sure as Dr. Gladman would say, any specific recommendations, please talk to your doctor, of course, about what might be right for you. But there is the question about, other than medications, are there vitamins that you recommend? And somebody is asking about diet and specifically turmeric. So that's a compounded question, but if you can speak a little bit to vitamins and diet, I think that's
so there's nothing specific about any particular vitamin or any particular herb that we know specifically works for inflammation. I know there's a lot of concept out there and perception out there that there is, but there's no scientific data to support it. My philosophy is, if you feel better when you take it and it's not too expensive, try it. As far as diet, on the other hand, this is a weight reduction diet. There is no doubt that that works. We now have some scientific evidence from a number of studies that demonstrate that people who have lost weight, and it didn't matter what diet they were on, if people lost weight, their psoriasis got better, and their psoriatic arthritis got better. So there's no doubt that people that are overweight would benefit from a weight reduction diet. Or I don't even call it a diet, I would say weight reduction lifestyle. Because what you want to do is you want to go on a plan that you can live with for the rest of your life, as opposed to a strict diet that you last on for a few months and then you'll fall off and put all the weight back. So.
Thank you so much. Again, it's a big topic, and so thank you so much for your being so concise and addressing it. And we're getting tons of thank yous and tons of praise for your presentation. I've already told you how grateful, I'll say it again, that CPN is for your time and your expertise tonight, Dr. Gladman. But I just wanted to impart that people are really appreciative of the presentation and of you spending time to answer many of the questions. We hope to have you back. Again, as research develops, we want to share it with our community, and we're grateful again to you for being available to do that with us. So thank you.
Thank you very much. Have a good evening.
Thank you. And I just want to wrap up by addressing a few of the questions that were more directed toward, I think, CPN. I'll be quick about it, again, respecting time. Yes, the session is being recorded. It will be available in French and English on our website for a limited amount of time in the next week or so. For if you are looking for any like questions that weren't answered, we're at info@cpn-rcp.com. You're welcome to email us. Our website is cpn-rcp.com. So you can contact us that way. We also have a free membership. It's very low barrier. There was a question about if there are support groups around psoriatic arthritis. We know this can take a huge toll on all aspects of life. We do provide information to our members about any events or programs that we're aware of. It depends on where you live. There might be some programming available. So again, send your questions our way. We will have our next webinar is set for October 26th. That will focus on difficult to treat areas of psoriasis. So if you're interested in learning more about psoriasis on the scalp, nails, genitals, face, and different areas that might be a bit more challenging to treat, please look out for our promotion for that event. And just another quick note, you should have received an evaluation in your email for this event. It's a SurveyMonkey. Please do take a moment if you can to fill it out. Some of the feedback we received moved us onto this Zoom platform. Hopefully it was a little bit more easy to access for people. So from our last event. So with that, I want to thank you so much again for spending your time with us tonight. We look forward to sharing the session by video once it's ready. And if you have any unanswered questions, please do share and we'll do our best to get back to you by email. Thank you. And with that, I'll close the webinar for tonight.